Welcome to the recent approvals episode of the ASCO University Weekly Podcast. My name is Thomas Karasic. I'm an assistant professor at the University of Pennsylvania, specializing in the treatment of gastrointestinal malignancies. Today we will discuss the approval of lenvatinib for the treatment of patients with unresectable hepatocellular carcinoma. As background to our discussion today, the only FDA-approved therapy prior to 2017 for hepatocellular carcinoma was sorafenib. This was based on results of the SHARP trial published in the New England Journal in 2008, which demonstrated an overall survival benefit of 10.7 months in the sorafenib arm versus 7.9 months in the placebo arm. In the 10 years after the approval of sorafenib, a number of phase 3 trials attempted to establish additional drugs or combination regimens in both the first-line and the second-line setting for advanced hepatocellular carcinoma, but all trials failed to meet their primary endpoint and no other treatments were approved. However, in 2017, 2 new drugs were approved for the second-line treatment of hepatocellular carcinoma: regorafenib, a drug similar to sorafenib, as well as the PD-1 inhibitor nivolumab. Lenvatinib is an anti-angiogenic tyrosine kinase inhibitor that targets VEGF 1 through 3, FGFR 1 through 4, PDGFRA, KIT, and RET. On August 16, 2018, lenvatinib was FDA approved for the first-line treatment of unresectable hepatocellular carcinoma. 2 different doses were approved: 12 milligrams for patients with actual body weight of greater than or equal to 60 kilograms, and 8 milligrams for patients with actual body weight less than 60 kilograms. The approval of lenvatinib in the first-line setting was based on the results of a non-inferiority study comparing lenvatinib to sorafenib for unresectable hepatocellular carcinoma. The primary endpoint of the study was overall survival. A total of 1,492 patients were recruited, and 954 patients were randomized 1-to-1 between lenvatinib or sorafenib. Lenvatinib was given at a dose of 12 milligrams daily for patients of at least 60 kilograms actual body weight, or 8 milligrams for those below 60 kilograms, while sorafenib was given at the FDA-approved dose of 400 milligrams twice daily. This trial met its primary endpoint of non-inferiority for overall survival. Overall survival was 13.6 months in the lenvatinib arm and 12.3 months in the sorafenib arm. While it met its endpoint for non-inferiority, it did not establish superiority in terms of overall survival. The hazard ratio for overall survival was 0.92. Lenvatinib did demonstrate a statistically significant increase in time to progression, 8.9 months in the lenvatinib arm versus 3.7 months in the sorafenib arm. It also showed a statistically significant improvement in overall response rate. Using the study endpoint of modified RECIST criteria, the objective response rate with lenvatinib was 41%, versus 12% with sorafenib. Using more standard RECIST 1.1 criteria, the overall response rate of lenvatinib was 19% versus 7% with sorafenib. Adverse events were common in both arms of the study, with 57% of those treated with lenvatinib experiencing grade 3 or greater toxicity, compared to 49% of those treated with sorafenib. Toxicities that were more common with lenvatinib included hypertension, proteinuria, hypothyroidism, weight loss, anorexia, nausea, and vomiting, while sorafenib more commonly had hand-foot syndrome and alopecia. Toxicities such as fatigue and diarrhea were similar between the 2 arms. The approval of lenvatinib marks the first positive frontline study comparing an agent to sorafenib in the first-line treatment for HCC. Lenvatinib demonstrated improvements in overall response rate as well as progression-free survival, and a modest trend towards improved overall survival, although this was not statistically significant. The toxicities of sorafenib and lenvatinib were largely comparable, although some toxicities, such as hand-foot syndrome, are more common with sorafenib, whereas hypertension and proteinuria are more common with lenvatinib. These study results established lenvatinib as a reasonable first-line option for the treatment of HCC, and choice of sorafenib versus lenvatinib can be made based on toxicity profile, as well as the symptoms of the patient that may dictate the need for an agent with a higher response. Pending results from the CheckMate 459 study, as well as other ongoing immunotherapy frontline studies, may well change the sequence of immunotherapy and anti-angiogenic therapy for HCC, but for now, lenvatinib is a reasonable frontline option. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on lenvatinib and the treatment of hepatocellular carcinoma, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.